Hi, my name is Amy Achiko, an MD candidate at the IU School of Medicine. Today, I'm going to be talking to you about ultrasound-guided brachial plexus blocks, specifically the Interscalene block. This is first becoming the standard of care in patients undergoing upper extremity procedures. First, let's briefly review the anatomy of the brachial plexus. The brachial plexus is a network of nerves comprised of the anterior rami of the lower cervical spinal nerves and the upper thoracic spinal nerves. This ranges from C5 to T1. This network forms different trunks, divisions, and cords that split into the terminal 5 nerve branches that control motor and sensory function in the chest, shoulders, arms, and the hands. Anatomically, the superior, middle, and inferior trunks emerge between the anterior and middle scalene muscles. It is critical to understand that there are also multiple vascular structures within this region, notably the subclavian artery, carotid artery, and internal jugular veins. All of these structures are at risk of injury during the interscalene nerve block. So what's the clinical significance of this particular block? The interscalene block is indicated for procedures in the shoulders, proximal humerus, and lateral two-thirds of the clavicle, as well as surgeries in the arm and elbow. Unfortunately, this block is not ideal for hand surgeries because C8 to T1 routes are spared during the block. Notable contraindications for the block include patient refusal, active infection and bleeding, especially in anticoagulated patients, contralateral paresis of phrenic or laryngeal nerves, and allergies to local anesthetics. Some of the major benefits of the interscalene block include excellent pain control. Patients who receive the block have been shown to have effective analgesia for up to 8 hours following surgery. This block has also been shown to decrease post-operative nausea and vomiting, with patients requiring lighter general anesthetic and less stay in the hospital. To briefly summarize the blocking technique, first, the patient lies supine with the head turned away from the side to be blocked. The posterior border of the sternocleidomastoid muscle and the clavicle are then used as landmarks to identify the supraclavicular fossa. Using a sterile technique, the ultrasound transducer is then placed within the fossa in an orientation that is transverse to the neck. The subclavian artery and divisions of the brachial plexus are identified. The brachial plexus appears as a hypoechoic circular structure, which is often described as bundles of grapes. The C5 and C7 to C7 routes will appear sequentially like a traffic light. A short bevel 5 cm gauge needle is then used to advance the local anesthetic between the C5 and C6 nerve roots. At this point, the spreading of the local anesthetic should be visualized around the nerve roots. Here is a movie recording highlighting the needle path to the C5-C6 nerve roots of the brachial plexus. Thank you, and here are my references.